Is Luis Verduzco, and I am an anesthesiologist and intensivist at a county hospital. We see a lot of trauma, specifically a lot of traumatic brain injury, which will be the topic that we will be discussing in this lecture. My hope is that by the end of this lecture, you will be better prepared for the USMLE Part 2 in regards to traumatic brain injury as well as the physiology involved in brain injury. And more importantly, that you will have basic principles that will make you feel much more comfortable the first night that you perhaps are in a trauma ICU dealing with a patient who comes in with, for example, a large epidural hematoma. So this is our content outline for this lecture. We're going to define traumatic brain injury. We're going to describe the different types. Then we will move on to the management of traumatic brain injury, focusing on cerebral perfusion pressure and intracranial hypertension, and then conclude with complications of traumatic brain injury. This particular lecture will be divided into 2 parts. So I'd like to begin with a clinical scenario of a patient that I actually took care of. So we have a previously healthy 55-year-old female who developed gastroenteritis, and while she was driving to the store to buy toilet paper, she syncopized and drove through a red light. She hit a tree dead on at 45 miles per hour and had a prolonged extrication by the paramedics. In other words, it took a while to get her out of the car. At the scene, her GCS, or Glasgow Coma Scale, was 8, and therefore she was intubated using inline stabilization. In other words, they were very careful with her cervical spine. She was then transported to the hospital, and evaluation in the emergency department was notable for hypotension, coma with a very left-blown pupil, and ST elevations in the precordial leads of her EKG. A limited transthoracic echo of her heart demonstrated severe hypokinesis of the midventricular walls with ballooning of the apex, for which she was started on dopamine. There was immediate improvement in her blood pressure. Full-body CT scanning was completely unremarkable except for a very large left-sided extra-axial hematoma that was causing severe midline brain shift. She was therefore emergently taken to the operating room for decompressive craniectomy. In other words, they removed part of the bone of the skull to allow that brain to come out this way as opposed to herniating down into the foramen magnum, which is the hole at the bottom of the skull that connects the brain to the spinal cord. So traumatic brain injury is essentially any external force that causes an insult to the brain. It can be categorized by mechanism, for example, blunt injury, which is an acceleration-deceleration kind of brain injury. It can be penetrating injury, where a projectile actually goes through the skull into the brain, lacerates the tissue, and there is tissue compression and expansion. Or it could be a blast injury, such as a grenade going off in what we see often in soldiers that go off and unfortunately are at war. And this energy is transmitted through the skull and through the vasculature of the brain, and you get very rapid brain edema over hours as opposed to over 12 to 24 hours that you see in the other type of brain injuries. The other thing that you see with blast injuries actually is cerebral vasospasm. You can also define it by morphology. For example, is it an injury that's diffuse or just focal, in other words, localized to one spot? So what exactly is the Glasgow Coma Scale and why do we use it? So Glasgow Coma Scale allows us to define the severity of this traumatic brain injury, and we define it as either mild, moderate, or severe by using the best eye-opening response, the best verbal response, and the best motor response. For example, if somebody spontaneously opens their eyes when I walk into the room, you'd give them a score of 4. They don't open their eyes no matter what you do. Either you yell at them, you pinch them, they would get a score of 1. For verbal response, just like here, they're completely oriented and having a conversation with you, it would be a score of 5. On the other hand, essentially they're just moaning and making sounds, they would score a 2. The best motor response would be a 6. If you ask them to lift their arm and they lift it, that would be a 6. On the other hand, if you are pinching them around their chest and they are attempting to reach the chest but they're not actually able to get to it, that would be localizing the pain, as opposed to, for example, if you pinch their body and they just sort of withdraw the whole body away, a general response, that would be withdrawal kind of score, which would be a score of 4. Now, score of 3 or 2 is flexion or extension, which is also known as decorticate posturing, which the upper extremities flex and the lower extremities extend. And then there is decerebrate posturing or extension, score of 2, where the arms go straight out and outwards and your legs are also extended. That would be a score of 2. So therefore you have mild, moderate, and severe injury. Any patient who has a score of 8 or less will get intubated. It's also known as, if your GCS is 8, then you intubate. If you come in with moderate or severe TBI, you automatically get a CT head. On the other hand, if you come in with mild TBI, there's actually multiple scoring things that you look at to determine whether somebody should get a CAT scan of the head. For example, if they are retching multiple times, if they have not returned to a score of 15 within 2 hours, it would be another reason to get a CT scan of the head. Obviously, if somebody has mild traumatic brain injury, but if they're on aspirin or Coumadin, they would also get a CT head. Now I just want to step back a little bit and talk about the cranial sutures, because that'll be important when we define the limits of an epidural hematoma. So the skull essentially is made up of multiple bones. You have the frontal bones, the parietal bones, the occipital bones, the temporal bones, and then there's other bones, but those are the big ones of the skull. And these are all connected via the sutures, which are fusion points that fuse over the first year. The reason a child is born with these sutures is a rapid brain development throughout the first year, having these sutures allows the brain to expand within the skull. Now, what are these sutures? So essentially you have a frontal suture, a coronal suture, a sagittal suture, and in the very back you have a lambdoid suture. Those are the big sutures. And as you can see at the very front, you have the fontanelle, the frontal fontanelle, and then you have an occipital fontanelle, which are those soft spots that you feel in a newborn. And I'll describe why the sutures are important in just a second. Real quick, I will mention that at these sutures, the dura is very tightly attached to the skull, such that you cannot actually separate the dura any further. So you have essentially this suture, and the dura is riding by below it, okay? And essentially the dura actually is able to slightly go into that suture and is very tightly adherent at those specific points. So let's turn a little bit here and talk about basic skull and brain anatomy. So you have these coverings outside the brain, which are called the meninges, the brain meninges. You have a dura, which translates to tough matter, the arachnoid, and the pia. The dura actually splits into two parts. You have the periosteal, which is the outer, and then you have the inner dura. That's important because the dura, when it splits into two, this split allows the formation of the cerebral sinuses, which are essentially the drainage system of the brain, that then leads to the internal jugular veins, which then leads to the right atrium and goes back, essentially back into your right ventricle, and etc. The brain has a total of 1.5 liters of brain parenchyma, 150 cc's of CSF, and 150 cc's of blood, both arterial and venous. You actually replace your CSF 3 times in a day because you make about 450 cc's of CSF per day. Your normal cerebral blood flow is you get 50 cc's of blood per every 100 grams of brain per minute. And this is maintained between a mean arterial pressure of 50 and 150. What that means is, even if your blood pressure goes up, as long as you stay between those two maps, the cerebral vasculature vasoconstricts or vasodilates to maintain cerebral blood flow at 50 cc's per 100 grams per minute, assuming that the brain parenchyma is normal. When you have injured brain, that vasculature's ability to autoregulate gets altered. Now, one of the common things that gets tested in the USMLE are sort of the layers from the outside all the way in of the anatomical structures. So just to run right through those, you have the subacute tissue. Then below that, you have something called the galea aponeurotica, sort of this thick connective tissue. Then you have the periosteum below that. Then you have the cranial bone. Then you have the dura, again, which has two parts to it, which is seen in this image right here to form the superior sagittal sinus. You can see here the dura splits into two to form the superior sagittal sinus, and it also, the inner dura actually ends up coming downwards to form the cerebral falx, which I'll talk about in just a little bit. So again, you have the dura, and then you have the arachnoid, the pia, then you have the gray matter, which are where the cortical cells are, which then give off the white matter, which are the axons. Okay, I have here in this slide the cerebral sinuses, which are again formed by the splitting of the dura. The main sinus is called the superior sagittal sinus, which runs right on the top. Okay. So let's discuss now the different brain injury subtypes. So the first subtype is called the epidural hematoma. So the epidural hematoma is an extraaxial hematoma. And what I mean by extraaxial, I mean that it is outside the actual brain parenchyma. It is often caused by an injury to the middle meningeal artery, which runs right here on the side. Okay, sort of a weak spot that often gets injured, and the middle meningeal artery runs right in this region, under the obviously under the skull. Therefore, you see an epidural hematoma adjacent to a skull fracture, and it forms this sort of lens convex shape. This is where the concept of the sutures are important. As you can see in this image, we are pointing to an epidural hematoma, which is pointed by this blue arrow, and you can see that it stops anteriorly at the coronal suture and posteriorly, probably around the lambdoid suture. And that is because, once again, at these specific spots, the dura is very tightly connected to the suture, and this blood that is essentially running right above the dura is coming this way, tracking until it hits that suture, and it has to stop. And because that blood can no longer go this way, it starts to push inwards towards the brain parenchyma, therefore forming this sort of lens-like picture. As like I said, it does not cross suture lines, but it can cross the midline. In fact, it's not uncommon to see an epidural that crosses the midline and presses the superior sagittal sinus downwards. Classically, these are patients who have an injury and they syncopize, or they have loss of consciousness, and then they wake up soon after that, and they have this lucid interval, and then a few hours later, they start getting kind of sleepy. Family members think that they just need to get some rest, and then they don't wake up because they end up herniating. Now, the next one is called a subdural hematoma. This is also an extraaxial hematoma outside the brain, and this is caused by injury to the bridging veins. And I'll describe what those bridging veins are in a second. It tends to form more of a concave or crescent-shaped picture, as you can see here by the black arrow. And this does cross the suture lines, and the reason for that is because the subdural hematoma, just like it says, runs below the dura and is not limited by the sutures. But because of that, it does not cross the midline, because once again, you have this dura that splits anterior at the very top and forms the cerebral falx, and because the subdural space is below the dura, that subdural space therefore ends up going also downward, and cannot continue to track this way to go around the midline. Often is caused by an acceleration or deceleration injury, and classically in the USMLE, you'll see it connected with a sentence that talks about an elderly falling or alcoholics. Now I'm going to go back to this picture to show the bridging veins. So the bridging veins you can see here on the left side of the picture says these veins that are connecting essentially the skull through the dura into the brain parenchyma, those get sheared and you get this bleeding into the subdural space. And you can see here that you also have the cerebral flux going downwards, and below, immediately below the dura, you have the subdural space, and that's where that blood tracks. Again, the epidural space and the subdural space are not real spaces in the brain. These are potential spaces, potential spaces that can exist if blood tracks into them. On the other hand, in the spinal cord anatomy, the subdural space does not exist as well, but the epidural space is a true anatomic space. The next slide is the subarachnoid hematoma. This is also an extraaxial hematoma. It is caused by injury to the pial vessels, which are vessels that are running in the pia. And this is blood in the CSF space. And what you see here pointed by this black arrow is part of the basal cisterns. So the basal means the bottom part of the brain. The cisterns is just a collection of CSF. And when you have essentially blood in these basal cisterns, and what you end up having is something called an obstructive hydrocephalus, because CSF eventually ends up draining via the arachnoid granulations into the sinuses. But if these arachnoid granulations get filled with thick viscous blood, it cannot be reabsorbed into the sinuses, and therefore you end up developing obstructive hydrocephalus, which means that you have an enlargement of the CSF spaces in the brain. We have something called ventricles, which are collections of CSF as well, which is where the actual CSF is produced. We have two lateral ventricles that are in this region, which are the main lateral ventricles, which then connect together to form the third ventricle, which is then connected via a little duct to the fourth ventricle. The fourth ventricle is found in the brainstem behind the pons. So you can imagine if, once again, if the CSF continues to be produced but it's not being reabsorbed, you have an obstructive hydrocephalus. Subarachnoid hemorrhages are caused by trauma, but they can also be caused by aneurysms or arteriovenous malformations. Classically, when a traumatic subarachnoid hemorrhage, you see blood not everywhere, as in this picture. This is more consistent with an aneurysmal bleed. Subarachnoids, due to trauma, tend to be focal subarachnoids. Now, one thing that's often tested in the USMLE is when you have these aneurysms around the circle of Willis, which is the part of the circulatory system, essentially, of the brain. At the bottom of the brain is a circle that forms these little aneurysms called Berry aneurysms, and those are associated with polycystic kidney disease. I will also mention that unlike traumatic subarachnoid hemorrhages, aneurysmal subarachnoid hemorrhages are associated with something called cerebral vasospasm, and that's what it means is when this vasculature in the brain begins to vasoconstrict, causing ischemia. Nobody really knows why it happens, but it can happen anywhere between 0 and 21 days. Classically, starts to happen around days 5 through 7, and you treat it with a medicine called nimodipine, which is a calcium channel blocker, for about 21 days. Another thing that you can see with subarachnoid hematoma is something called SIADH, or syndrome of inappropriate ADH release, or cerebral salt wasting syndrome. Both of these syndromes can lead you to have hyponatremia. But in cerebral salt wasting, the physiology is that you are losing salt, and because salt attracts water, you're losing a lot of salt and a lot of water, and you have a high urine output and essentially a hypovolemia, which you treat with volume resuscitation and salt tabs. And the other thing that you can do is give fludrocortisone, which is essentially the equivalent of aldosterone, that binds to the ENaC channel in the distal collecting tubule to help you reabsorb sodium and water. On the other hand, SIADH, as we can imagine, because you have high levels of ADH, you have a lot of reabsorption of water via the vasopressin 2 receptors that leads to a decrease in urine output, and you also get a hyponatremia. In these patients, what you want to do is fluid restrict them to minimize the hyponatremia. The second to last hematoma I want to describe is an intracerebral hematoma, which is an intraaxial bleed, which is within the brain. And this can be caused by trauma, again, arteriovenous malformations, or a tumor. And in this situation, often the hematoma goes into the ventricles. And in this picture, you can see this bright white stuff in the middle of the brain is actually blood. And on the you can see these black spots, and those are part of the ventricles. You can see the blood is in the ventricles, and you're going to get a significant hydrocephalus as a result of this. This is a pretty a very poor prognosis. The last one I would describe is called diffuse axonal injury. So diffuse injury of the axons, the white matter. This is often caused by traumatic shearing of the axons, and as expected, it often happens right at the junction of the create and white matter, right where the axon takes off from the cell body. CT scan is very poor at seeing this diagnosis, but MRI will show these sort of black spots, which you can see with the blue arrows in the image in front of us. Again, it has a very poor prognosis. The next thing I will discuss is brain herniation. And when we describe herniation, we talk about a herniation as either supratentorial or infratentorial. The tentorium is a dural. The tentorium, what it is basically a dural extension that separates the cerebrum from the cerebellum. The cerebrum from the cerebellum. Here in this image, it's the indentation that you see going inwards, right below number 1 here in the diagram, that black sort of indentation that you see in this picture. So there's multiple types of herniations, but the key ones that I want to talk about is number 1 is the uncal herniation. And uncus is the medial part of the temporal lobe, which is number 1 here, herniating downwards through the tentorium cerebelli. And what ends up happening is that this is what leads to that blown pupil history. And the reason that happens is because you are pressing on cranial nerve 3, the oculomotor nerve. The oculomotor nerve, along with 3 other cranial nerves, 7, 9, and 10, facial, glossopharyngeal, and vagus, contains parasympathetic activity and specifically it has it around on the periphery of the oculomotor nerve. So one of the first things you will see is a blown pupil, because the parasympathetic part of the cranial nerve 3 is what causes your pupil to constrict when you have a light shining on it. But because it's being pressed upon by the uncus, it loses that function. The nucleus of this parasympathetic function is called the Edinger-Westphal nucleus, which is found in the midbrain in the posterior part of it. The other cranial nerves of importance for parasympathetic function are cranial nerve 7, which provide function to the lacrimal and mouth glands, cranial nerve 9, the glossopharyngeal, which provides function to the parotid gland, and then cranial nerve 10, which is the vagus nerve, which is sort of the father of parasympathetic function, which gives parasympathetic function to the heart, the lungs. Classically, you get the bradycardia, the bronchoconstriction for the lungs, inability for the GI system to function. The other thing I want to talk about regarding the uncal herniation is something that's tested called a false localizing sign, or Kernahan's notch. So the right side of the brain, the motor cortex on the right side, gives function to the left side of your body. What happens is these cells send axons down towards the midbrain through the cerebral peduncles, which are the anterior part of the midbrain. Immediately thereafter, they cross towards the opposite side of the brain, and hence the reason that the right side gives function to the left side. But if you can imagine that if I have any kind of herniation, that for example, if I have a herniation on the left side of my brain, that then for some reason causes pressure on the opposite side of the brain, it will essentially press on the cerebral peduncle on this side, and therefore the motor axons that are coming from this side will be injured or pressed upon, and therefore the left side of the brain won't the left side of the body's motor function will be injured. So that's why it's called the false localizing side, because the dysfunction, the left side, is on the same side as the initial brain injury, right? So you would expect the right side not to work, but here it's the left side. And the reason, again, is because this hematoma on this side is causing counter pressure on the opposite cerebral peduncle, and therefore it's preventing the left side from working. Again, called the false localizing sign. Another injury that you see is a subfalcing injury, or the cingulate gyrus injury, and that's right in this middle region, right below the cerebral falx, in the middle region. And what you have is pressure on the anterior cerebral arteries run right here and give blood supply to the frontal medial lobes, which is where the function of the legs is. In other words, these are where the motor cells that provide function to the legs exist. So what you have in this situation is weakness of the legs, but normal function essentially of your upper extremities. We have something called the homunculus, which basically means that the motor cortex provides function to the legs around this region, and then it walks over to essentially the upper extremities. So injury here will affect your upper extremities. Injury here will affect your lower extremities. Then the last one I will conclude with is the infratentorial herniation, which is tonsillar herniation, which is what we're talking about here is the cerebellar tonsils. And what happens here with cerebellar tonsils would be number 6, is that it begins to press on the foramen magnum, which is that hole at the very bottom of the skull, and begins to compress the lower brain stem as well as the cervical spinal cord. Okay, this is where the cardiac and the respiratory centers exist. One of the things that is often tested in the USMLE is the hypoglossal nerve, or cranial nerve 12, and its motor function. Cranial nerve 12 provides motor function to the tongue, and the tongue always points towards the side of the lesion. What does that mean? The right cranial nerve 12 pushes the tongue towards the left, and the left cranial nerve 12 pushes it towards the right. So these are always in a balance. So if I have a lesion of my right hypoglossal nerve, the tongue will deviate towards the right, because this cannot push this way, but this maintains its function and pushes it this way. Okay? The hypoglossal nerve originates in the medulla, which is the most inferior part of the brainstem. The brainstem has 3 parts: the midbrain, the pons, and the medulla. The medulla connects to the cervical spinal cord. Okay? I'm going to go ahead and conclude with the 2 major dural divisions of the brain, the cerebral falx and the tentorium cerebelli. The cerebral falx runs in the middle part of, right between the 2 cerebral hemispheres. It is created by the dura. Recall the dura comes across this way, separates into 2. You have the periosteal layer, and then you have the inner layer. Between those 2 layers, you have the superior sagittal sinus. That is the drainage system of the brain, which eventually ends up draining into the 2 internal jugular veins. Anteriorly, the cerebral falx, which again divides the 2 cerebral hemispheres, attaches to a bone called the crista galli. In between the 2 cerebral hemispheres runs the anterior cerebral arteries, which provide blood flow to the medial part of the frontal lobes. The medial part of the frontal lobes give motor function to the bilateral lower extremities. So if you have ischemia of the anterior cerebral arteries, your bilateral lower extremities will not work. Okay? Then you have the other division called the tentorium cerebelli, which basically divides the brain into a cerebrum and a lower part called the cerebellum, as well as the brainstem. This is important because when you have uncal herniation, the region this occurs is because you have this tentorium cerebelli, and the uncus, or the medial part of the temporal lobe, herniates downwards through and into the tentorium cerebellum, leading to that pressure that we described in a previous slide regarding the pupillary dilatation. This concludes part 1 of the TBI lecture. In the next in part 2 of the TBI lecture, I will discuss not only TBI management, but I will focus on two key concepts often tested in the USMLE: cerebral perfusion pressure, intracranial hypertension. And then I will conclude with complications of traumatic brain injury, one of which is often tested in the USMLE, and it's called Takotsubo's cardiomyopathy. Okay, we will see you in just a bit.